Thank you all for being here. My name is Eric. I'm the Executive Director of Jett Foundation, and we couldn't be more pleased to be in person here in Dallas today. I heard a few people earlier talking about just what life has been the last couple of years and not really knowing who's under the mask or what they look like or how tall they are or anything around that. And I'm still bald. So those of you that have seen me on a Zoom call, I continue to be bald to this day, even with a mask on and off. But it's just been a tough few years being locked into our houses and behind closed doors. And we are so excited to be here in person today and so excited to see all of our partners here with us today that can make this possible, as well as all of our families that we have been really waiting to just get in touch with and back in front of. So with that said, we are here to talk about our educational workshops, one of our key pillars. And I figured I would introduce a few of the staff, and then as you will find throughout the day, we have enough time for you to get around and meet each other as the day goes on. So with me today from the Jett Foundation staff is Maura Carroll, if you raise your hand, Maura. Maura is our Director of Development. It's been with the organization, I would say, the longest standing employee, 13 years. So we're happy to have her here joining us today, as well as Julie LeClaire in the back, who was, you all met when you registered this morning to come in. So that's who's here on the Jett staff, and feel free at any time throughout today's events to pull us aside, ask any questions you have. If we can't answer those, we're happy to get the information to you. I truly believe that collaborative work for our families in Duchenne is necessary, and we can't do it alone. So we'll find information for you if we can't answer ourselves. So with that said, we'll move into today's activities. This gives you a little bit of a layout of how the day is structured. And again, if you need to stand up, walk around, get some fresh air, you can totally do that. But we're going to start the day. I'll give you a little rundown here in just a minute on Jett Foundation. If you're not overly familiar with what we do, we'd like to tell you a little bit about who we are and what we're charged to do day in and day out for our Duchenne community. Then we have some really good, informative speakers here that we're excited to introduce to you. We'll do a little bit of break. We have some parent perspectives that we always enjoy, really what true life looks like inside the homes of our families. Couple more presentations, and then all of our partners will get up and talk a little bit about what's going on with their treatments that are out there. So, any questions thus far? All right. Jett Foundation started. If you go and Google Duchenne and foundations, you're gonna come across Christine McSherry. She's a force in the Duchenne community. The foundation was formulated about 21 years ago when Jett was diagnosed. And Christine wanted to find a way to provide information about Duchenne that wasn't really readily available at that time, and also make Jett's name synonymous with Duchenne and this disease. So we've been around. We celebrated our 20th anniversary last year. Super exciting, although COVID made it a little less exciting in terms of having a big gala and things of that sort, but it's been 20 great years of serving the community. Today, Jett Foundation has evolved. We have 4 major pillars that we provide services for our community. Awareness and engagement, family guidance and support, community and education, which is what we're here today with, and independence and empowerment. We, over the course of the 20 years, we spent a lot of time in research at the beginning of the days with Jett Foundation, and we went through a strategic plan this past year and really went out to our key partners in the community, our friends, our community, our families, and asked, what are we doing? How are we doing? And what should we be concentrating on for the next 3 years or so? And out of that came a variety of great information, but one of them was continue to do what you do and do it well, and that was our direct service programs for our families. And this was our new mission statement that came out of that, that we worked on with our board of directors. And I would just make a little bit of a emphasis on empowering people and families impacted. So all of our programming is not just for the individual that's been diagnosed, but all of the family members that may have a part in that journey through Duchenne. So caretakers, friends, grandparents, the whole 9 yards. So that's our new mission statement moving on for the next couple of years. So independence and empowerment, we have two key programs. These are cornerstone programs, and one of which is our Camp Promise program, which is camp. So we have a free camp for individuals that are affected by Duchenne, and it's just like you read about or you see in the movies. It's a stay overnight camp, a lot of water, there's all sorts of activities, but this is, you show up, staff take care of you, it's 1-to-1 ratios, and it's no different than what it would look like. We have cabins, we have campfires, we have s'mores, and a ton of activities, and it gives the family, the caretaker, a little break, so they can dive back into their own self-care while we take care of having fun at camp. So we offer 5 camps, 3 of which are our traditional. 6-year-old is our youngest, and we have no upper age limit. So we're the only organization right now in the country that has no upper age limit. So it provides that connectedness that so much of our campers enjoy. I had the pleasure of participating in our Colorado camp, hands-on as you would think, from getting up in the morning, getting ready, getting out of bed, getting changed, brushing teeth, going to breakfast, onto the activities of the day, the whole experience that you would expect in camp. We offer the day-long six to no upper age limit in Colorado, Washington, and Camp East, which this year was in Pennsylvania. We also have 2 retreats, which is just for the 18-plus category. So those are in Arizona and Ohio. So a truly remarkable program. I can't say enough about it to you. Camp Promise Connect is what we've learned over the past few years is we need to be inclusive, and not everybody can make it to camp. So the virtual world, and what COVID did for us is actually, it changed the trajectory of our organization. So we realized we can reach far many more people by being virtual. So we have a lot of different activities that bring all of our campers together throughout the year on a virtual level. So that's what Camp Promise Connect is. And it provides a place where our guys can connect year-round, and not just at one time if they make it into camp. So it's been a blessing to have that program. This brings it to life. Raise of hands, how many people have been up in a hot air balloon in this room? Go ahead. We've got 1. Our camp, the gross majority of our campers at Camp Promise East in Pennsylvania went up in a hot air balloon. It was a really, really cool experience. You can see in the bottom, you see me in there. That's the Colorado camp. And gives you an idea of, you're going there to create relationships, long-time relationships, and have fun. So, any questions about camp? To here? That's a great question. There isn't a very close camp to here. Pennsylvania. Yeah, so if you look at things that we're considering for next steps is camp somewhere down southeast, this area, and then we're out into probably California, Southern Cal, are some of the areas that we're pinpointing in ways that we can bring the services that are no longer being provided as much. So that's a great question. The other part of this sort of pillar is our we have a Jett Giving Fund. So there's two arms of the Jett Giving Fund, the Accessible Vehicle Fund. If you can imagine, we can imagine how financial situations with Duchenne, it's over the top. There's a lot of need for medical equipment and everything that goes along with taking care of the family. Our Accessible Vehicle Fund is a grant program that we offer once a year, and families apply for this program. And if they get selected, they're partnering with us to raise 50% or more of the cost of the vehicle. And once they raise that part, we come in and fill the rest. So we typically have about 10 vans that we donate a year out of this program. And you can imagine the impact it has in a family that's gotten to a point where they can't stay connected with their community because they don't have the means to get a power chair into a vehicle and get out into the community. So this is a truly impactful program that we continue to see a lot of interest in year in and day in and day out. Second arm of our Jett Giving Fund is our emergency fund. This came sort of at the end of COVID, right? A lot of people started doing emergency funds, and I loved the idea, but I'm a little bit of a business guy here. I'm like, how are we going to sustain this? Because an emergency can happen today, tomorrow. It's not just COVID. And I wanted to, if we're going to offer an emergency program, I want to make sure that we can sustain it so that we have an opportunity for families to apply to this program whenever the emergent need is there. We've helped a lot of families with hurricane assistance. Most recently, we called all of our families that were in Florida and asked if they needed help after the hurricane went through there. So this is it's an ongoing grant program. You apply online. There's only a few things that you need to provide for our review, and we have a small committee, and we turn around smaller grants sometimes in 1 week, sometimes a couple days, depending on what the needs are. General needs that we help with are rent assistance, mortgage assistance, utilities, food insecurity. Sometimes it's transportation to get to medical appointments and things of that sort, to clinical trials. So, we're there, and there's an other in there because sometimes you just can't put everything in a category. So we take a hard look at these individuals and the circumstances that they're going through, and it's been a truly remarkable program to this point, and we see that continuing along for many more years. Just a quote. I think that says it all. Well, we all know why we're here, a little bit of education. And truly what we're looking to do from an organizational standpoint is to get to the underserved areas across the country in some cases, and make sure that we're bringing our pharma partners, our clinicians together, and families to provide what's not always the same in terms of access to good education around Duchenne. So we do that as well as bring it to areas that we're going to hit as many people as possible. So we're here today for that reason. Little plug for, this is our third in person as we've reworked ourselves back into getting in front of our community. And we also have community webinars that run quite a bit throughout the year. Next year, we're going to be in Gainesville and Minneapolis, as we have two more as well that are getting locked in at this point. So our community webinar series, as I said, it's an opportunity for our pharma partners to get in front of the community with updates on what's happening on the clinical trial basis or on the development of their treatment, as well as other information that we get from the community of topics that our communities are asking for more information about. So we are constantly talking with our ambassadors and our connections in the community to bring meaningful education to our families. I just mentioned our community ambassadors. You know, Jett Foundation is a small but fierce little group of individuals. There's 10 of us, 10 mighty warriors in Plymouth, Mass. And as you can imagine, we're serving the United States, so 10 people, you know, you get stretched pretty quick. So we engage volunteer ambassadors across the states in order to be individuals there that'll advocate for their community, be a phone call away for either newly diagnosed or people that just, families that just want to talk to somebody that's been through it or to socialize. And we also grab as much information as sort of the word on the mouth on what's happening on the streets so that we can bring it to our partners, we can bring it to our staff and look at anything that's out there that we feel that we're not going to have to duplicate, but we can provide help in, assistance in this. So we get a lot of direction from our ambassadors day in and day out about a variety of topics that may be out there. So truly a necessary and thankful program because, as I said earlier, you can't do it alone. So this is a big part of who we are. We have a family support group. So the support groups is for moms and caretakers. It meets twice a month virtually. And this is a place for moms to get together and talk, to help each other, to learn from their own experiences, and to talk about other things that are out there that we may not necessarily be aware of. We get a ton of good, valuable information here that we share constantly with our partners in groups and individuals. And I think it gives us a real, gives parents a real safe ground to really discuss what's going on in their lifetime. So if you know anybody that's looking to connect and they don't have a big social network, this is an area that I would highly recommend for families to connect and dive into. So we also will be bringing that back on the ground in '23. So there'll be 2 to 3 in-person porch nights, and we will likely utilize our educational workshops and piggyback on that and have a porch night on one of those nights so that we have a nice group of individuals here, and then there's a little bit of mom fun in the evening. I'm not allowed to go, so I don't quite know what goes on in that arena, and I don't want to know. So, many ways to follow us, certainly where things are these days, social media. Please look at our handles and follow us. I would say email anytime you have a question, those that are in our families out there, a question or you've heard something that you think might be a great topic, please let us know. We're looking to collaborate. We're looking to find a way to serve more and more intentfully. So once again, we can't do this without our sponsors. So grateful to all of you that are here today that support us on an ongoing basis. And it takes many, right? It takes a village, and I'm a firm believer in collaborative work. There's a lot that we can do, and I'll say from the foundational standpoint, there's a lot of foundations in Duchenne, and we certainly need to work more closely together, so we're not duplicating efforts, and we're making things stronger together is the way of the game. But thank you for all of our partners here today, for everything that you do. But we're going to move into our first presentation today, which is recommendations and accommodations, including physical education and adaptive physical education. It's going to be presented today by Melanie Valle, physical therapist, Children's Health and Rehabilitation Services, Children's Health and Specialty Center. So with that, I'll bring Melanie up for her presentation.
He's worried about pronouncing my last name right when he did great. So I am Melanie Valle. I am a physical therapist. I have worked in the multidisciplinary neuromuscular clinic at Children's Health in Dallas for 6 years. And I'm just very excited to be here today. I see a lot of familiar faces, so we're just glad to be with you guys here this morning. So today we're just going to kind of talk about the guidelines that we have for safe participation in physical activity for children with Duchenne, and how children with Duchenne can participate in PE class at school and other activities like recess in a safe way. And then we can discuss how the needs of these children will change over time in the school system, and some do's and don'ts of physical activity with children with Duchenne. So in general, in the school system, we really try to encourage participation in desired physical activities, but the goal is typically to participate, not to strengthen muscles. So along with that, we want to avoid any over fatigue or muscle exhaustion, because this can actually lead to further muscle breakdown. And this is typically by avoiding activities that are focused on muscle strengthening, so things like lifting weights or repetitive activities that can cause the muscle to break down. In order for a muscle to strengthen, we actually have to push it to the point where it breaks down, and then when it goes to rebuild, the muscle gets stronger. But there's an impairment there with children with Duchenne, and so the muscle actually doesn't repair itself in a stronger way. So we want to kind of prevent the muscle from getting to that point of breakdown. And there's certain activities that cause more breakdown in the muscle tissue, and these are called eccentric activities. And this is when you're strengthening a muscle that is in a lengthened position. So, for example, if you're doing a bicep curl and you're holding a weight and you bring it up in this direction, the muscle is shortening. That's a concentric activity. But when you're lowering that muscle or that weight down, the muscle is actually lengthening, and that's called an eccentric activity. And that type of activity causes a little bit more damage to the muscle tissue. And so in general, we try to avoid those. One of the things we like to encourage in school is to focus on stretching activities. Typically, you work at school, they have a physical therapist available in the school system. That therapist will evaluate your child and help come up with recommendations for what physical activity is going to look like for them at school. And that therapist works very closely with us in the neuromuscular clinic to make sure that the guidelines for this specific diagnosis is being followed. So we like to modify activities that might be too difficult. One really important thing to do is provide frequent rest breaks and make sure you drink plenty of water. And overall, we're just trying to avoid any falls in the school setting because this can result in fractures. So the school therapist's job will be to kind of help assess the school environment and look for any areas that might be difficult to access or or if your child is participating in PE, to help modify those activities to make them appropriate for the child. With any physical activity, you want to monitor for any signs or symptoms of muscle breakdown or fatigue. And this can include pain or cramping during an activity or up to 48 hours after you perform an activity. This is called delayed onset muscle soreness. So, you might have lifted something one day and then you don't feel soreness or cramping until 48 hours later. That means that you did too much with activity and you want to avoid doing that or modify it in the future. Excessive fatigue or exhaustion, so after you get home from school, if you're just kind of completely wiped for the day, have to go straight to bed, That might mean that you did a little bit too much that day. Shaky muscles while performing the activity. If you're trying to lift something and it's a very shaky movement, that can mean that that activity is too difficult. Or if you're unable to complete it through the full range of motion. Any increase in falls, and then you'll want to monitor for any dark or coke colored urine. That can be a sign that there's too much muscle breakdown happening. So in the school setting, we really want to focus on working with the school PT. The school PT is kind of our eyes in the school. Everybody's situation is a little bit different in school. Your school is going to look different. You might have stairs, you might have elevators, you might have ramps available. Some schools don't. So the school therapist is really the eyes and ears inside of the school to help make those modifications specific to each child. And our job in neuromuscular clinic is to make sure that you're getting the right accommodations, and if you're having any issues, we help work with the school therapist to make sure they understand the needs of a patient with, or a child with Duchenne. So we help to educate schools, teachers, especially PE teachers, about the specific and unique needs of children with Duchenne, because they might not have had a child with Duchenne in their classroom before. It's not, some schools have never seen this before, so we're there to help educate them on the unique needs of that child. And then participation in PE will look different as your child ages through the school system. And our job in clinic is to help continue to communicate how those needs change. So this is kind of hard to see, but this is just a sample of a form that we use in our clinic, and it has specific guidelines for what is expected in the school system, what accommodations are expected or needed, and this is how we communicate with the school and the school physical therapist to make sure that they have the information that they need to accommodate this child. So it has things like adaptive physical education, allow a child to use an elevator, also things like providing extra copies of board work for our kids who are getting tired, writing notes, or are allowing them to use a computer instead of doing all of the handwriting. It just has a lot of different recommendations like that, and this is a good way for us to communicate with the school about any needs that they might have. So early on, we really try to encourage as much participation as possible, but just in a modified way, making sure that teachers and coaches are aware that rest breaks are needed and activities should be modified. So an example would be if the PE coach wants the whole class to run 5 laps, this child could run 1 lap or something like that. And then we want to make sure that we're working with the school PT consistently to make sure these activities are modified appropriately, and evaluating the school for any high fall risk areas. So this could include things like uneven surfaces, stairs and steps, or areas with increased numbers of obstacles. So if you have any issues with these things at school, please talk about it with your neuromuscular clinic provider, and we can help make those modifications. As the child ages through the school system, more of like those middle years at school where we're still walking but we're having more falls and balance issues, we want to be really careful because these falls can become more frequent and they can result in fractures. So we want to make sure any walking is done with assistance, and we can focus on exercises that incorporate more of stretching or use of arms that can be performed in a seated position. So things like seated yoga, throwing and catching a ball, modified bowling. And this is a great time to also look into wheelchair and adaptive sports, and we'll talk a little bit more about that, but there are a lot of different adaptive sports available. So for kind of those later years at school, if you're in a PE class, we typically recommend focusing more on stretching and activities that are focused more on stretching the arms. And then we also recommend performing tilting in the wheelchair, and this is where you raise your feet up to the heart level or above heart level. This is an important activity because it helps with circulation in the legs, and it helps bring that fluid back through the legs up towards the heart. So this is something that can be performed during a PE class for an older child. And then this is an example of an adaptive wheelchair that can be used for soccer. And it has like the cage in front that you use to hit the soccer ball, and the joystick is how you control it. And this is something that that I saw through the UT Southwestern here has an adaptive sports expo, and it's really cool. They have a lot of different sports, and it occurs every fall. So I think the one for this year has already happened. It's typically in October, but it can be a great expo to go to if your child is interested in sports and wants to play sports, but they have a lot of adaptive options. So it's a really cool expo if you're interested in any of that. So kind of in summary, our do's and don'ts. We don't want to ever force a child with Duchenne to perform an activity that's too difficult. Sometimes we have families come into clinic and say, my child wasn't able to run a full lap, and the coach was really getting on to them. And part of that is just education and the helping the coach at school understand that it's not the child trying to get out of doing the activity, that they really are just having trouble completing that, and that they need modifications, and actually forcing them to do that can be harmful to them. So a lot of it is just education. We have had families, after we've provided this education, come back and still have the same issues at school. And if that should happen, we have at Children's, we have a school services department, and we have social work that can help get involved and make sure that our kids are getting the accommodations that they need. So instead of forcing them to perform an activity that's too difficult, we want to allow them to modify that activity so that they can still participate. And that's going to look unique to each child. So some, it might just be reducing the weight or reducing the repetitions. And for some kids, that's going to be using an adaptive wheelchair or participating in an adaptive sport. We also don't want to push a muscle too hard so that it becomes overly tired or over fatigued. We want to allow rest. We do want to allow rest breaks as needed, and avoid any traditional strengthening activities that will cause more muscle breakdown. And we don't want to have a child with Duchenne sit out during PE and not do anything. Sometimes we have families come in and tell us that this is happening. You really want to work with your school physical therapist to and then your neuromuscular specialist to come up with a plan that allows your child to participate in an adapted manner. And that's pretty much it. So any questions? Okay.
I think you're good.
Okay. Great.
How about a round of applause for Melanie? Thank you so much.
Thank you. Oh.
Our next presentation is going to be on mental health and psychosocial care in DMD, presented by Dr. Kaitlin Batley, Assistant Professor of Pediatrics and Neurology at UT Southwestern Children's Health in Dallas. So with that, Kaitlin, it's all yours.
Good morning, everyone. I'm Kaitlin Batley, and I'm a neuromuscular neurologist at UT Southwestern and Children's. And I'm really excited to see all of you guys here today, and thank you to the Jett Foundation for hosting us and inviting me to speak today on a topic that's really, really important to me, and one that I think we don't focus on quite enough, and I'm hoping that we're going to be changing that in the future. And so I'm excited to discuss a little bit with you guys today. And please, I'd love for this to be informal, and if there's anything that you guys, hear me say or see on my slide and want to talk more about, please just shout out. I'd love to really tailor this to what you guys want to hear. I kind of guessed as I was putting it together, so just let me know. All right. So I think historically, descriptions of DMD have focused a lot on the way that DMD affects muscles. And a lot of people maybe in the community who aren't as familiar, that's what they think of when they think of DMD is, a muscle disorder. But we know a lot more about it these days, and we know that, dystrophin, the protein affected in DMD, is actually expressed in a lot of other places in the body, including in the brain. And because of this, we can, sometimes have some symptoms that come along with the brain. And dystrophin is expressed throughout it, but it can be even more in particular areas that are important for things like learning and memory and emotional regulation. And so that can kind of go along with some of the symptoms that some people will notice. And so once we started kind of focusing a little bit more on the effect of dystrophin in the brain, there have been numerous studies by a lot of different groups who have tried to kind of characterize the way that DMD affects the brain. However, they had a really hard time with this, and the studies all had varied results because just like, every single one of us is different, every single, child with Duchenne is different. And so there really is no one set of things that you should expect or will see or will experience. It is absolutely unique to every single person. And so although there was nothing they could say kind of hard and fast, they did see some kind of, commonalities in that sometimes children with Duchenne would have a little bit more trouble with things like verbal skills. And so that could come along with, speech production or reading, and then also with attention and memory. And so the most important thing to say is just like in, every other, general population, there will be varied, intelligence, varied skills, varied things that some people are good at and others are not as good at. And so DMD is, just like that. There are some boys who will struggle a little bit more in one area than the other, but the vast majority of boys will have normal intelligence and normal cognitive skills, and a lot of this talk in the beginning part won't apply to. But we do know that there is an increased risk for neurodevelopmental disorders, and that can include things like autism spectrum disorder or intellectual disabilities or specific learning disorders, as well as other mental health disorders. And so I'd like to kind of have this be a part of what everyone talks about as well, so that way we're able to kind of spread awareness of these disorders that might not be as common, but that we can still see, so that way we're aware, we can identify needs earlier, and then we can also, intervene earlier. And so that's why we'll be talking today. So again, early screening is important, having these discussions early is important, so that way we are not missing anything. So when I think about psychosocial care in DMD, it really is kind of a wide gamut of things. And it starts all the way in really early childhood with development, goes on as kids get older and social skills and interacting with peers and others in the community. And then at school age, things like learning and academic skills and behavior and mental health throughout the lifespan as well. And so when we think about development, that can be often the first thing that families or maybe your pediatrician might identify as a concern, and sometimes that can be gross motor delay. That's a really common reason why I'll see patients referred to my clinic. But in other cases, it can actually be speech delay that's more common. And, by no means are these kinds of delays specific to DMD. There are an infinite number of reasons why a child could have delays in these areas, but it is something that can kind of be one of the first presenting signs. And then getting a little bit older, when we start getting into school age, things like learning and academic skills. We do know that some children with DMD will have more issues with what we call working memory, which is that short-term memory when something is kind of taught to a person and they have to kind of start encoding it into their brain or actually being able to kind of make it stay there permanently. It goes first into an area called working memory, where then the brain kind of processes it to put it into your long-term memory. And so this can be especially troublesome with things like verbal information. And then impacts on attention and concentration can also play into this, because if you're having a harder time paying attention to what the teacher is saying up at the front of the classroom, it can be harder to put into your working memory as well. And we also have seen that specific learning disorders can be more common in children with DMD as well. The most common one that we'll hear about is dyslexia, which is a reading disorder that we'll talk about in a little more detail in a second. But there can also be specific problems with mathematics or with writing as well. And so dyslexia, you can think of if somebody is having more trouble with their verbal processing, so of words and speech and written word as well as trouble with kind of encoding these memories, it can make problems with dyslexia more common. And some of the early presenting signs can be difficulties identifying letters really early on. And then as we get towards working to learn to read, being able to sound out words and really process through the different sounds that each letter or short combination of letters makes, that can be a little bit more challenging. And then going on through school, difficulties with spelling as well, and sometimes noticing that words or phrases can be flip-flopped, or maybe focusing on one part of the word and not the rest of it. Those can all be kind of early signs that maybe there's a problem with dyslexia. And the reason why it's important to notice this really early on is because there are specific treatments that can, help a child overcome these issues. And so there can be intensive phonics instruction that the school can provide, and then different ways that we can accommodate in the classroom to help minimize these challenges. And so in order to identify some of these specific learning disorders, there is a set of big long day of tests called neuropsychologic testing, and this is performed by a clinical psychologist, and they do, usually it's at least half a day of different kinds of puzzles and quizzes and different ways that they're able to test each of these memory processes and each little bit of the cognitive functioning that goes into learning, so that way we can identify where do we need to focus more and maybe put some special attention in that area in order to, really help a child to be successful. And so this testing can often be done, it is done by the school systems, but it's often something that you have to ask for and really advocate for to get the kind of specific testing that's most helpful. And sometimes, like Melanie was saying, the schools won't have as much experience with particular medical diagnoses, and so that might not take into account, what's really causing some of the issues with school when they're making their recommendations. And so in that case, it can sometimes be more helpful to have a medical team kind of refer and order the neuropsychologic testing, although that's not a perfect system either, because I know that there's a really long wait list for our particular program. So usually I try to go about it both ways, and then we make it work together with the two. And so once we make these diagnoses and once we identify areas where we might need some extra support, then there are laws in place that mandate the schools to kind of reinforce these things. And again, we are oftentimes providing education to the teachers in the schools about what strategies can work best, what things to focus on, what things to kind of provide extra support. And so that's our job as the medical team. And we've got resources that we can help, as well as parts of our team who can reach directly out to schools to kind of reinforce this. And so that's part of our job as the medical team, is to help with those things. But just some kind of basic examples, more for younger kids than I see a lot of our friends in the room. But to be able to kind of focus on things that require, one step at a time, more so than giving a really complicated command, because if you are having trouble holding attention on one thing and encoding your communication into working memory, it can be really hard to remember to go to your backpack, take out your folder, open to the third page, write your name on it. That's just too much to go at one time. And so breaking things down can be helpful, repeating information and providing kind of as distraction-free of an arena as possible for important things like test taking. Those are some of the basic strategies that can be helpful, more so for our younger kids. And then, as we have talked a little bit already about attention, we do know that there's a higher incidence of attention deficit hyperactivity disorder, abbreviated ADHD, much easier. And so that's something that we just kind of want to be aware of, so that way if we're seeing symptoms, we can intervene again. So there are kind of a couple of different subsets of ADHD, and the symptoms can present really differently. So knowing that, it's not a, just a little box where everyone looks the same in ADHD as well. There can be some signs of impulsivity. So that can come out as interrupting other people, or, doing something without maybe thinking it through, or saying something without thinking it through, which happens to all of us at some point or another. But maybe if it's happening excessively and becoming kind of disruptive to the child. Also, hyperactivity, so fidgeting a lot or being unable to stay still or sit quietly to attend to a task can be another sign. And then inattention is actually the one that a lot of people kind of forget can be a sign of ADHD, I think, because this can present as forgetting to do something, forgetting to take the homework out of the folder and turn it in, losing things, so forgetting to put the folder in the backpack and not knowing where you put it. These are things that sometimes we can forget are signs of ADHD and actually a medical diagnosis, and not just not caring about your homework. And so again, with these kinds of things, there are different kind of modifications we can make in the environment, school plans, reminder charts, and then behavioral therapy can be helpful as well. And we also have different medications that we can use in the treatment of ADHD as well. And some of the common ones that you may have heard of are the first class alpha-2 adrenergic receptor agonists, which are medicines like clonidine or guanfacine. And these can impact levels of the chemicals in your brain in order to kind of help with that attention and that focus. And then other classes that I think more people are familiar with are the stimulant medications, so things like Adderall or Ritalin can also be helpful as well, and kind of work similarly in modulating those chemicals in the brain. Of course, all medications come with the potential for side effects, and so some medicines could be helpful for some people and not others, and so kind of tailoring these things is a really important thing to discuss with your medical team as well. And also, we always have to talk about the increased incidence of autism as well in patients with DMD. And because of this increased risk, we are always screening, especially in our littler kids early on, to see if there are any signs that are associated with this disorder. And a lot of the really early issues are things that I've talked about before, with things like trouble with communication or delays in speech, which of course are not specific for autism, but can be seen in autism. And then some things that are a little bit more commonly seen with autism alone are things like repetitive movements, so hand flapping or spinning in circles or something like that, as well as trouble with changes in routine. I like routine as well, but for children with autism, it can be really, really distressing to say, flip up your morning routine. So you wake up in the morning, you brush your teeth, you get dressed, and you have breakfast. But say it's a super busy morning and you're running late for school, and so you say, we got to wake up, get dressed, brush our teeth, get in the car, eat breakfast in the car, and that change can be really, really distressing. And so that could be something that, a family notices, that they bring up to their doctor to start this discussion as well as things like playing with toys in a way that is kind of not their intended use. So say having a toy car, and instead of, zooming the car along the ground, maybe they're spinning the wheels. And so just playing it with a little bit differently than traditional. And so these kinds of signs can be of autism, although not specific for it again. And we do utilize some formal testing in order to make this diagnosis. And again, it's important because there are specific treatments that can be helpful. One of the kind of biggest treatment that we utilize is called ABA, or Applied Behavior Analysis Therapy. And this kind of therapy is becoming increasingly covered by insurance. And so having that formal diagnosis can be important to get this kind of therapy for a child. And then again, different kinds of strategies we can use in the environment in school to accommodate, as well as medical management of different symptoms if they happen to be present. And so next we'll get into the big topic of mood disorders. And one of the reasons that I feel so strongly about talking about this today is because we all have either heard or felt stigma of mental illness, and the way that this can impact the way that we talk about it and the way that we share what we're feeling and what's really going on. And so I want this to be something that, you can talk about openly with your medical team and with your families, and something that we increasingly recognize as it's part of care of the whole person, just like we talk about medicines for your muscles and we talk about different respiratory treatments. This is no different. And so I really I want to make sure that we all kind of can talk together. And so, we do see depression, anxiety, and different mood dysregulation disorders, just like anybody who is dealing with a chronic illness, and the different kind of changes that can happen along that journey can lead to things like feeling sad or worrying about things or anger. And so these are things that, we have to be able to talk about. So that way we're able to, intervene and treat and, improve everybody's quality of life. Starting with our younger kids, mood disorders can often present as behavior issues. Especially if a child also has autism, we can see that. And then we can also see that in a really big way after we start steroids. And that's a common thing that our patients will have to face is the things that they can feel after they start this medicine that their medical team has recommended and believes is helpful for them, but can come along with a side effect. And so in younger kids, we're often able to treat these kinds of feelings with something called play therapy, which is a really cool method of therapy that utilizes play. It is at our hospital we have a playroom, and it is with a trained therapist who is able to incorporate different toys and allow children to express themselves with the way they play with these toys and empower them, and it's really a beautiful thing. And so that can be a helpful strategy in younger kids. And then as kids get older and they're a little bit more able to kind of communicate and speak about their feelings, then being able to do more traditional kind of like talk therapy. Again, we have medications that can be helpful in dealing with behavior issues. And the first one is the one I talked about for ADHD. And so that's a medicine that we can sometimes use one medicine to cover a couple of different symptoms. The medicine's clonidine and guanfacine. And then we also have medicines that are in the class of atypical antipsychotics, which I know sounds a little bit weird because that's not really what we're using them for here in this case, but medicines called risperidone and Abilify, they can be helpful in kind of regulating some of those behavioral issues, and if there's any kind of like behavior that causes a child to maybe be unsafe, like hitting their head, then these medicines can be really helpful for that as well. But again, they each work on different chemicals in the brain, and they can each come along with their own side effects. And so a thorough discussion is really important. And so when we talk about depression, it is depression and DMD, just like depression, any kind of, disorder, or even just people in the general population who aren't dealing with another kind of medical disorder. We can see changes in sleep patterns, so either sleeping a lot or maybe sleeping really not very much at all, but something that's different from baseline. Disinterest in things that a child used to really like doing or want to do, kind of disengaging a little bit. And then, of course, being sad or crying can be one that we more commonly associate it with depression, as well as changes in eating, again, eating too much, eating too little, and sometimes even physical symptoms, so having a lot of headaches or stomach aches that seem to come up kind of out of nowhere, and maybe we don't find another medical reason for them, like not a lot of acid reflux or other symptoms that could actually cause the physical symptom. And then just knowing, like we talked about with behavior issues, that little kids can have different symptoms of some of these feelings of sadness, and they can present a little bit more with kind of irritability and anger. Anxiety is also a huge topic, and kind of normalizing that everybody worries, and that's part of our lives. Is we've always got something to worry about, and so that's typical. But sometimes the worrying can be so much that it's interfering with the ability to just do your regular activities because you're just too worried. And so these are the times where maybe the worry is so great that we need to bring it up with the medical team. And certainly if you're noticing things like panic attacks, which can be extremely distressing and come with a lot of physical symptoms and scary ones like chest pain or trouble breathing, that's when we might need to talk a little bit more about treatment as well. And so identifying these things early on before they get too severe can be really helpful. So that way we can start our interventions, start our treatments and management with therapy like I discussed before. And then also we have a lot of different medications that can be helpful. The most common class of medications that we use, and they're the most well studied and very effective, are the groups called SSRIs. And they, again, like all the other medicines I've discussed, work on different levels of chemicals in the brain, and this one being serotonin. Examples of these that you may have heard of are Prozac or Zoloft. And so these can be really helpful, but of course, also come with potential side effects. And one of the important things to discuss is the black box warning of these medications for the use in children and young adults. And so having kind of an open discussion that, this medicine has a very, very rare chance to actually make you feel a little bit worse, and actually thoughts of wanting to hurt yourself is something that we always discuss, because this needs to be, again, an open discussion, and we want all of our boys to be able to speak about this if they notice that side effect and not stay silent. But the much more common side effects are things like upset stomach and some dizziness, and that usually gets better with time. And so these medicines can be really helpful. And so just to kind of recap and summarize a little bit through the ages, the different things that we talk about at each visit and look for. So in the really little kids and toddler age, preschool age, this is when we're doing our developmental assessments, seeing if we would benefit from any speech therapy or physical therapy. And some kids will even do some early childhood programs that allow them to go to a school where they can get all of these therapies. And that's available through the school district. And this is when we often do our autism screening, and we discuss behavior at every visit as well. And then getting a little bit older through elementary school, this is when we really need to start kind of involving our school team, getting them up to speed, educating them, and letting them know what's going to be best for each individual child. And of course, these recommendations will vary for every single person. But knowing that we can adapt some things in PE, so that way we're able to participate more and not simply told, well, you can sit over there and watch everyone. That's not appropriate and that's not fair. And then the same way with things that are in academics is being able to allow extra time on tests, or being able to type instead of write, or whatever is needed to allow each of our kids to be successful. So the 504 plan and individualized education plan are really important for those things to, we have it in writing, the school can refer to it, they know what to look at, and it's also an agreement between the families and the schools of what the school will provide. And so that's an important thing to have in place and to formalize. And then again, behavior and mood screening, broken record, but this will continue too. And then through adolescence, some of these same things kind of continue on, but we have to adapt as kids get older. And then this is really where transition of care becomes important and where we start to talk about this more. Because just like, I'm sure all the adults in this room can remember, going through as a teenager is the time where you really want your independence and you want to be able to make decisions for yourself. And, we make mistakes along the way, we learn. And so this is the same for every person. And so learning how to become independent and to make decisions for yourself, this is something that's so important and something that we want to facilitate as the medical team, and that we want to help you guys also to kind of have these conversations and really, make sure that we're doing what, our kids want and following through with what they think is important is the most. And so that's when we talk about that there. And then I can't leave you guys without just the one slide on caregiver mental health as well, because this is something that I feel really deeply that the phrase "you can't pour from an empty cup" is so true, and the importance of taking care of yourselves as caregivers, and making time for your own doctor's appointments and your own dentist appointments, but also the things that you enjoy and recharging, because I know that our families give so much to each other and are so supportive of each other. And so just to kind of continue doing that. And then reaching out to family groups like Jett Foundation. The porch night, it sounds like such an amazing thing and something that, I wish that everyone got the opportunity to do. And so we're starting to talk about it a little bit more. And so if you have friends who think would benefit from doing that, please send them a link. And then just to kind of be able to be there for each other, because none of us will truly understand what you guys are going through on a day-to-day basis. And I think that, support with other families is one of the most important things. And we want to be here to facilitate that in any way that we can. So if there's ever anything where, you want to get connected with other families, or if you're ever one who wants to reach out to families who are maybe new in the diagnosis, let us know, because we're always looking to connect and be able to support other families in that way. Okay. That's all I've got. Any questions that anyone wanted to discuss, or I'll be, come find me at lunch. Yeah. Yes. Mm-hmm. Yes. So all of the medications that I discussed, I am very comfortable prescribing, and our colleagues are as well. There will be some instances where maybe some of these medicines don't work for a particular child, and we'll reach out to a psychiatrist to help a little bit more if we need to try a few other things. But certainly we can get things started in neurology clinic. Very comfortable with that. All right. Thank you guys so much for your attention. And if you think of anything later on, please come chat with me.
Thank you so much. We appreciate all your insights. Next, I'm really excited. We're going to bring a parent or individual perspective to the group today. And I'm really excited that we have a couple individuals that are going to come up and talk a little bit about their perspective and anything they want to share with the group. And we're going to start with our friends Paula and Dan, and they come to us locally, and also have an organization called Finn's Friends, and they'll probably talk a little bit about that as well. So welcome aboard, you two. You're up. Do you want me to do something?
No, just catch me if I pass out. A little nervous. So, hi, I'm Paula. My husband Dan. We have.
Here, I'll get it right here. See if I can work this right here. This is our family. This is, we have a daughter who's 24, Madeline. She is a recent graduate of Arizona State, and she just got married to the cute one on the right, Max, in September. And then we have Taylor, who's 18. He just started his freshman year in college at Blinn in College Station. And then we have Finn, which is why we're here today. We're extremely grateful to be here. I think sometimes when we speak at events or whatever, about the first 5 minutes, everyone's eyes kind of gloss over. And so, you know, being here with people who get it, our people, we're just extremely grateful for this opportunity to tell our story. So thanks for letting us be here. So before I tell Finn's story, I just want to do a brief kind of family background. I had a cousin. That's Finn.
Yeah, there you go.
Good, you can go to the next one, I think. I have a family background in Duchenne. This is my cousin Michael. He was diagnosed in 1986. He was 2 years younger than me. You know, there wasn't a lot being done about Duchenne then. We didn't know a whole lot other than the Jerry Lewis telethon. That's basically all the information we had. And so growing up, it was maybe one of those things that we just didn't talk about, you know. We saw the progression, of course, as he began to get older and fall, and then eventually into a wheelchair. But they lived in Kansas, and so it was kind of we were a little removed from that because we lived here in Texas. Michael was very smart. He was extremely brilliant. He attended, of course, high school and then 1 year at college. He unfortunately lost his battle with Duchenne in, I think it was 2003. And so anyway, moving forward, we had another cousin who was diagnosed, and I think he was about 3 years old, and since we already had the family history of it, we knew the signs of what to look for. So this is Ethan. He's now 19 years old. He attends Wichita State. He has a 3.6 grade point average. He is studying physics and astronomy. He's living on his own. He has 2 aides that come in and help him do his, you know, daily things he needs to be done, but he's thriving. He, I think the only really standard of care that he is on is his heart and lung medications. They opted out of steroids, and so he's doing actually really well. He had a spinal fusion surgery a few years back that actually corrected his posture, and he's doing really, really well. So I'm happy to report that. And then there's Victor. Victor is 14. He lives here in Dallas. He goes to Rowlett High School. Also, an amazing kid, doing really well. And so those are the 3 boys in our family that were affected by Duchenne. And so I tell that story to say that you would think with all of this history that we have that our diagnosis would have been easier. When Finn was diagnosed, it really made me realize that I didn't ask any questions. You know, I wasn't involved. And so I don't know if anyone has family members that you would expect to be super supportive. I will say, being on both sides of the fence, I just a lot of times didn't know what to say. I didn't know the questions to ask, and so it made it really difficult when Finn was diagnosed. I just didn't have a full grasp on what that would look like. So diagnosis day, let's back up. Finn was born in September of 2017. He was 9 months old when his doctor recommended that he get tested just based on family history. And so it was a simple CK test. It came back in 24 hours. Our doctor called us on the phone. I was in Target, or in the parking lot. And I remember her saying, you know, Paula, his levels are high, and still you would think I would even know what levels are. I didn't even know what that meant. And I said, well, what's normal? And she said, probably 1 to 300, 1 to 500. I said, well, what are his? And she said 26,000. And so we knew he had it. And I'm sure a lot of you can still remember your diagnosis day. I remember driving home and just remembering the sky was different, the trees looked different. My perspective on life was completely changed forever. And so I went home. Dan was out of town. He was in Florida on business, and that was a tough conversation to have. He flew home, and then we got recommended to see a doctor in Dallas for diagnosis, or for actual diagnosis and for genetic testing. And so we did that. It was confirmed. He has a deletion of 3 through 21. And so we did some research. We connected with families online. We had a lot of forums we joined on Facebook. And we just wanted to find the best doctor. And so Dr. Wong was highly recommended. I remember I called her office and left a message, and within like 30 minutes, Dr. Wong calls me on her cell phone and talked to us for almost 45 minutes. And so we knew we had to see her, and we flew to Boston, Worcester, and met with her. And she's been our doctor ever since. Finn is doing well. He started steroids about a year and a half ago, and the change that we saw in him was pretty instant. He's able to jump, run, play, do all the things. He keeps up with his peers pretty well, and so he's in pre-K. He's a jokester. Mm-hmm. He loves to, just do everything that boys his age like to do. We have seen recently maybe a little bit of frustration, behavioral type stuff. There's been no weight gain. There's been not really anything crazy with the steroids at this point, and so we're happy that we took that route. He's on a 15 milligram dose of Emflaza, and that's pretty much it right now. We did... Okay.
Oh, sorry. I don't know what slides are on here, so.
So anyway, that's Dr. Wong, and that's her clinic. And so then moving forward, we knew we wanted to do something. Neither one of us are those types of people who just kind of sit back and let people tell us what to do. And so we knew we wanted to be proactive in the fight. I remember when we had to do his blood work, it wasn't in the clinic. I had to take him to a lab in town. And of course, it was a fasting lab, and so he couldn't eat. And we were, we go to this blood work for him it's terrible. It's traumatizing for sure, and so he couldn't eat, and it was terrible. And I got him donut holes before, and then after he did his blood work, I got back in the car, and I remember I just sobbed like a baby. Like, how is this our life, But then, I don't know, call it God, I don't know. I had this idea or this thought, like, how much worse would this diagnosis be if we didn't have the comfort? It was cold that day. If we couldn't get in our car and turn the heat on, or if we couldn't get donuts for Sweet Finn, or if we had to sit at the bus stop to get to these appointments. And it just, from that point forward, we just knew like we had to do something. We had to help others. And so we did that. We created Finn's Friends in 2020. And you want to talk about Finn's Friends?
Sure. I'm Dan, everybody, and you don't have to remember our last name. I gifted her with that. So.
It's not the only thing.
Well, so anyways, we live in Longview, Texas, which is about 2 hours east of here, the Piney Woods. And like Paula said, when we were diagnosed, I was in Orlando for work, and it was just a bizarre feeling, to be honest with you. And really, we spent that first probably, 6 months to a year trying to wrap our head around what we were dealing with, even though Paula had quite a bit of family history with it. You just don't know what you don't know. So we kind of zigzagged the country trying to get answers and understanding what we were dealing with. And once we kind of gathered our thoughts and what direction we want to go with this, we realized really quickly that it was nice to be able to go to doctor's appointments and get on a plane and pay for a hotel. But we really interacted with a lot of families that struggled to do that. And so Finn's Friends was born much like the Jett Foundation, even though we are a long ways from where y'all are at. But like Eric and I were talking earlier about just collaborating together with one mission in mind, and that's, in our case, a 5-year-old boy that's 2 hours east of here with his grandmother right now, and a lot of other families that are struggling. And so we don't know what we're doing with it, to be honest with you. We are trying to remember to keep receipts, little things, right? So the accountant doesn't stop, he stops yelling at us. But as terrible as a parent it is with a boy with Duchenne, and obviously, you know, with Finn, like we want him to play sports and ride bikes and stuff. You realize real quickly, he just has a new normal. And a lot of the actual boys that we've met with this disease, it's their normal. And they're actually incredibly happy, very content people. And I've drawn a lot of inspiration from that. And so Finn's normal may just look a lot different, and so will other boys like him. But the reality is that we're going to fight for Finn, but really when we say Finn's friends is really all of you, but it's all of his unique friends like him. And we're going to work really hard to make sure that, you know, his time on this earth is well served and he impacts the community just like what the Jett Foundation is doing and having these amazing events. And so we've had a lot of fun. We've interacted with a lot of cool people and met a lot of new friends in the community. We have a golf tournament and a pickleball tournament, which I have no idea what pickleball was until last year and thought it was the weirdest game, but people are pretty intense about that. And it's been interesting. These events have really, people rally around this community in an amazing way. And we're extremely appreciative of that. Finn's an amazing boy. Paula runs it. I just try to stay out of the way. But I don't know. Our perspective is that we've met amazing Patricia's back there with PTC. We've gotten to know her. She's amazing. And so it's not only the parents, not only the boys, it's not only people like Eric from the Jett Foundation, but it's also all of the partners that they have here and their amazing impact. The first event we went to, guys, was up here in Dallas, and I left at 3 with a migraine because I could not get my head wrapped. I mean, as a father, we're fixers, right? We're going to fix everything, make everything better. I left that event and go, I'm in way over my head. But I drew a lot of comfort from companies like y'all's that are like doing, and doctors that are doing absolutely amazing things to help the boys that are affected. So thank y'all and everybody for doing that.
Do you want to talk about Finn's Friends and what we do and who we support?
I just did.
Oh, okay. Sorry.
Oh, sorry. I think that's it.
Yeah, that's it.
Any questions
Any
for us?
questions?
Thank you.
I think we talked.
Thank you so much.
Thank you both so much. Wonderful story. And it's such a pleasure seeing both of you and meeting both of you here today. So again, thank you and best of luck to the foundation. I'm sure we're going to be on the phone talking quite a bit over the next several weeks and months to come. So thank you. We have next Amanda here with us today that's going to share a little bit about her journey, and we'd like to invite her forward. So Amanda, you're up.
Hi, my name is Amanda. My son, we just were approved this year for Jett Foundation Giving Fund. So we're, getting a vehicle this year. So very excited about that. I just wanted to share a little bit of my perspective, my background. So I had 2 brothers with DMD. Both passed away in 2016. And just, being a sibling and then now being a parent, it's very different. It has a lot of familiar, I'm very familiar with it, but at the same time, it is still very new. My 2 brothers, we have a family history of DMD, and my mother, she's from Guyana, she's from South America, so my grandmother had a sibling with DMD as well, but we didn't make the connection until my brothers were about 8. This was in the 90s. My second oldest brother, he started having difficulty. He fell, and then he just
didn't recover. Like, I remember one day, you know, we're riding bikes together, and then the next day it was like, oh, you know, my brothers are now in a wheelchair. Like, when did this happen? Like, you know, being a little girl, I didn't think, you know. I just thought, oh, okay, you know, we didn't make that connection. And so it just became a new normal for me. It was just very, you know, just adapting to them. They're in a wheelchair. We had, you know, a huge support system. You know, we had grandparents there with us, my dad, you know, so it was just kind of like getting used to that, the changes there. You know, I never thought of anything like, oh, my brothers are, you know, they're in a wheelchair, they're different. I never once thought that. So, you know, just, you know, being around them, helping them out, day-to-day activities, you know, they were amazing. They were both amazing, great individuals, and their journeys were very different. Like people say, you know, each DMD child is different. You know, my brothers were completely different. You know, one had more needs, one had less needs. Personality is a little bit different too. And then I had my son. So Darren is over here drawing. So I had my son, so I kind of, you know, we already knew, you know, the connection was there. When my brothers were diagnosed, that's whenever they found out, hey, it's hereditary, it's passed on, you know, your daughter could be a carrier. I do have one younger brother who actually was not affected by DMD. So it was just, you know, learning that, you know, okay, you know, not every male is going to have that. You know, you don't really know unless you're, you know, get tested to see if you're a carrier and so forth. So when I had my son, I had an inkling that, you know, hey, there's a 50% chance that he's going to have DMD. So I had him with that expectation that, you know, I could possibly have a child that has DMD. So I had him, and he was diagnosed when he was 5. So he was diagnosed. I kind of already knew because he had that, you know, walking a little bit on his tippy toes, things like that. So I kind of knew. I knew what to expect, you know, and it's just coming into this, and then, you know, having my own child, I'm very, you know, my parents were very, they were going with the flow. They were going as things were happening. Like, I feel like for me, I still I have that, like, I'm like, okay, this and that, we got to do this. Like, I'm trying, like, very organized. You know, my parents, they were going with the flow pretty much, which has helped me. It's helped me a lot, you know, not have so much anxiety, like, oh my gosh, my child, you know, things like that. But yeah, I think everyone's perspective is very different. And my dad always tells this story about, I don't want to get emotional, but this one's really hard for me. He always tells the story about how, I'm sorry. He always tells a story about when my parents found out that my brothers had DMD. They, you know, my mom was sitting on the edge of the bed, and she was looking out the window, and I was pushing my brothers on the swings. They were already having a hard time. I was pushing them on the swings, and my mom was she was breaking down. My dad, you know, my dad came up to her and, you know, held her and said, hey, you know, just think about this. By the time Amanda's an adult, you know, and her, you know, she's lost her brother, she's going to know what love is, and she's going to know, you know, nothing's going to really bother her, because she's going to have to, she's already been through so much that she's going to know, like, you know, all the small things, it doesn't matter. It's the bigger picture, you know, all the, you know, things that could happen, things like that, you know, she's not going to make a big deal about these things. She's going to know what's important, you know. So I think that was very, my dad, he's right here also. So my dad, he, you know, he gave a lot. He really did. He, you know, he was, the last couple years in my brother's lives, he was their caretaker. You know, we had nurses that came in and helped, but my dad was the one that was there doctor's appointments, you know, just pretty much doing everything, you know. So it's just, you know, it's very different. And I do want to say, you know, there's a great support system now, you know, with children with DMD, muscular dystrophy. So there's a huge support system, which is different, you know, as my parents were coming up with my brothers, they were just kind of thrown into this. They didn't really know what to expect, what to do, how to get help, you know, things like that. It was just kind of learning as they went. So, you know, I'm fortunate. I'm glad, you know, I got to experience my brothers, and then it kind of prepared me for my son. So, yeah, it's just, thank you guys so much for coming out, and thank you, Jett Foundation, for letting me come up here and just kind of share my perspective with everyone. Thank you guys so much.